Thank you very much, Virginia. And thank you to the organizers for inviting me to attend this meeting and to come and talk with you about image guidance in radiation therapy. Now, my talk follows very naturally from Dr. Gregoire's, who has just explained to you how critical imaging is in radiation therapy in identifying the tumor volume. Excuse me. And perhaps you heard some of the talks this morning about accidents in radiation therapy, where it was pointed out that in radiation therapy, radiation protection really means protecting the tissues that you're not trying to treat, the normal sensitive organs. And so I'm going to show you how image guidance contributes to both of those in radiation therapy. Now, I first need to disclose to you that my institution has research agreements with manufacturers, some of whom equipment I will be talking about, and that some of this equipment is not cleared by either the FDA or the CE mark in Europe, and so are not for sale just yet. A lot of this is very new stuff. I will say a little bit about the origins of image guidance in radiation therapy and touch on the benefits, and then talk about some recent advances and the introduction of MR into guidance of radiation therapy, and how MR can contribute to patient positioning, treatment planning, and treatment delivery. And then I'll finish up by saying just a little bit about biology-guided radiation therapy, a very new expression. And this all comes about from the experience with surgery. Atul Gawande is a surgeon in the US and who is also a very prolific writer about medical issues and improvements in medicine. And one of the things he points to is that surgery is by nature invasive. And that's bad. And there should be ways, and he foresees ways over the next few years, of eliminating invasion. Well, radiation therapy has always been about avoiding invasion. And radiation therapy has made big steps forward as techniques have improved and has replaced surgery in some diseases or some stages of disease. And as we continue to develop techniques, we'll continue to do that. Our techniques do improve. As Dr. Gregoire pointed out, we have moved from what we called conventional conformal radiotherapy, or even simpler 2D treatment planning and delivery, where we treated large volumes of tissue in order to make sure we encompassed the gross target volume and the clinical target volume. And we've moved from that to modern techniques such as IMRT and VMAT, tomotherapy, radiosurgery, and ion beam therapy, as you see listed here, with the goal of improving cure rates and reducing toxicity. And image-guided therapy contributes to that by helping us see what it is we're aiming at and trying to treat and what it is we need to avoid. I'm going to point to a couple of articles here, one of which Dr. Gregoire also mentioned. And so I will only remind you, as he did, that this study, in part, demonstrated how important the quality of radiation therapy was. And what he didn't mention was that, in fact, the poor quality of some of the radiation therapy delivered on this trial masked the benefits of combined chemotherapy and radiation, which was actually the goal of the study, to demonstrate that. Dr. Gregoire showed you a very similar graph to this. Mine is looking at loco-regional failure-free survival, not overall survival, but the result is exactly the same, that in patients where the quality of radiation therapy was high, the yellow curve up here, survival was quite good. In patients where the quality of radiation therapy was not so good, was not compliant with the protocol, then the results were very poor, very much worse than otherwise. We know that imaging is important. Dr. Gregoire has shown you this, but I'm going to show you another aspect. On the left is a CT scan taken when the patient first came in to be prepared for radiation therapy. This is what we call a simulation CT scan. And on the left, superimposed, is the dose distribution that was planned for this patient. This is a prostate case. The prostate is in blue, the seminal vesicles are in red, and the bright pink isodose curve surrounds that target volume. That was on the day of simulation. On the right is a CT scan taken a week later, when the prostate has changed shape and moved posteriorly. The seminal vesicles are tilted posteriorly and downward, and part of the prostate and all of the seminal vesicles are now outside of the target volume. And by the way, these two sets of CT images were registered based on the bony anatomy that you can see very clearly there. What's happened? The problem is that on the day of simulation, the left-hand picture, the rectum shown in green was quite dilated from fecal matter or from gas, whereas a week later, not surprisingly, the rectal volume was completely different, and it was far less dilated, allowing the prostate to move back. If we had known that, we would have changed the treatment plan. But at the time, we didn't know that. And a study of these patients done at my institution, MD Anderson, showed that patients whose rectal diameter was less than 6 centimeters at the time of simulation had a far better outcome than patients whose rectal diameter was more than 6 centimeters. Significantly different outcome, just because of that change that we could and now do predict over the course of therapy. We didn't make adjustments in those days. We now know that we can use image guidance like this to make adjustments during the therapy. And when we do that, again, here are data showing that the results are better. On the blue curve, for both local and loco-regional control of the tumor, the blue curve shows when image-guided radiation therapy was used, and the yellow curve shows patients in which it was not used. And the outcome is significantly better when IGRT is used. And that's for two reasons. One is, with IGRT, we knew, in this study, they knew how to aim the radiation beam and were able to treat the tumor more effectively. But the second reason was that when the physicians were using IGRT, excuse me again, they were more comfortable in delivering higher doses because they were more confident that the radiation was going to the tumor. So patients did better both because the tumors received the dose and because they could deliver a higher dose to the tumor. As we move forward and reduce our field sizes, we begin to use what we call radiosurgery or stereotactic body radiation therapy, stereotactic techniques with greater conformality, higher dose to the target, a much steeper gradient around the clinical target volume, and much lower doses everywhere else. And the graph on the left shows the increase in number of publications about radiosurgery, showing that improved imaging allows us to better delineate the tumor and plan treatment. And on the right are the number of publications which also have increased on stereotactic body treatments, showing again that image guidance allows us to deliver much more conformal treatment, focus on the tumor and avoid normal structures. So is image guidance a brand new thing? No. We have been using some form of image guidance for a very long time. This is a picture taken in the 1970s of a cobalt unit with an X-ray tube mounted on the side of it. By rotating the cobalt unit 45 degrees, you could take an X-ray image of the patient to demonstrate where the radiation beam was going to go. And this gave us what we could consider image-guided treatment with the patient in the treatment position and the opportunity for real-time corrections if you consider real-time waiting for the film to go through the processor and the tech to run back with it. Nonetheless, adjustments could be made before the radiation beam was turned on for treatment. Now, our equipment has improved. Here on the right is a picture of a modern LINAC with what we call onboard imaging to take those same sort of X-ray images for image guidance. And here's a couple more pictures. Again, a modern accelerator with an onboard X-ray imaging system. In the lower picture, a similar device. I don't believe this system is ever actually available anymore, but it also allowed image guidance using X-ray tubes mounted in a circular gantry, so that again, the patient could be imaged by orthogonal beams, X-ray beams, and the position of the patient verified or adjusted if necessary. And there are other techniques mentioned here. I'm going to come back and talk about cone beam CT in just a minute. But before I do, here's another system that uses orthogonally directed X-ray beams to confirm the position of the patient before treatment. And a similar device called the CyberKnife also uses room-mounted X-ray tubes to do this. At MD Anderson, we use CT guidance a great deal, and in several of our treatment rooms, we have CT scanners mounted on rails in the treatment room, so that when the patient is positioned on the treatment couch in preparation for treatment, the couch is rotated and a CT scanner is moved over, and a CT scan, a diagnostic quality CT scan, is made to verify the patient position, make adjustments based on the patient's position today, and then after those adjustments are made, the patient is swung back around under the LINAC for treatment. And being able to use this sort of CT LINAC technology has enabled us to reduce the irradiated volume, do a much better job of protecting normal tissues, deliver heterogeneous dose distributions if we wish, where we can deliver higher doses to the volume we believe is active growing tumor, and do a better job of protecting the normal tissue. So these sorts of developments help to make image-guided radiation therapy an alternative to surgery, where we can focus the radiation dose distribution right down on the target. Now, I've mentioned motion, but what I haven't talked about is respiratory motion. And of course, that's not the only kind of motion that can affect the movement of tumors and target volumes, but it's critical. And here is a good example in the upper panels of a treatment plan that was prepared for a patient, patient with a lung tumor that is shown outlined in yellow here, showing that on the actual day of treatment, the tumor was not in the volume receiving the high dose. And again, my previous slide showed the effects of rectal filling, and similar effects are seen with peristalsis. Here's an example of respiratory motion, which of course is a much more rapid motion that takes place during the treatment delivery. If we could account for that, we could turn the beam off when the tumor moves out of the radiation field, so-called gating, or we could move the beam to follow the motion of the tumor. But CT in the treatment room is not really practical. Our current image-guided technologies, again referring back to our KV systems mounted on the LINACs, really rely on the availability of bony landmarks, or where bone is not visible on implanted fiducial markers, or, as I've alluded to, cone beam CT, which can be registered with the planning CT. And cone beam CT has really transformed our practice. And it's quite possible that we haven't exploited all of the possibilities that cone beam CT brings us. But it falls down in a couple of areas. It is not good for visualizing soft tissue structures. Here in the lung, it does a pretty good job, but in the abdomen, CT is not so good, especially cone beam CT is not so good. It doesn't give us any functional information, so it doesn't tell us where in the tumor we really need to focus, and it takes too long to acquire cone beam CT, so we can't address intrafraction motion the way we'd like to. And that's where MR can come in. MR gives us tremendous soft tissue visualization. It has the potential to give us real-time 2D and 3D imaging, or so-called 4D imaging, where we can make a cine image in 2 or 3 dimensions without having to implant fiducials or use surrogates. There's no imaging dose, which can become important, especially with pediatric patients or people with sensitive normal structures. And with MR, we have the opportunities for quantitative and functional imaging to tell us much more about the tumor. So different MR sequences show the anatomy and the physiology in many different ways and enable us to identify not just the organ, but where the tumor is within the organ. Dr. Gregoire showed you some examples, and here's another. On the left, our CT scan shows us that there is something there blocking that air cavity, but on the right, we can really see the extent of the tumor in the oral cavity, and we can also see an enlarged lymph node. Even I can see that on the MR. And with advanced pulse sequences, here an example in the prostate, we can get much more information about function and learn about the tumor itself, where tumor cells are actively growing and where they're not, with spectroscopy and other imaging techniques, such as some of the ones shown here. And access to these imaging technologies, these pulse sequences for MR, really separate radiation oncologists from other cancer specialists, because this shows us where the tumor is and how to get to it. I mentioned motion a few minutes ago, and again, we can perform 4D CT scanning and demonstrate motion, but in the abdomen, we can't see anything other than the diaphragm moving, whereas in the lower images of an MR scan taken in a 4D mode, we can clearly see the motion of the tumor, our target volume, so we have the potential of tracking it. Now, introducing MR into a radiation therapy department is something to be very cautious about. We're not accustomed to MR. We're not familiar with the effects of strong magnetic fields, and we have to take concerns to avoid inadvertently carrying non-MR safe objects or patients containing non-MR safe objects into our exam or treatment rooms. So it's a paradigm shift for us in radiation therapy. But we're dealing with that several different ways. Remember my example of CT on rails? Well, here's how Princess Margaret Hospital in Toronto has introduced MR imaging into their radiation therapy department by putting an MR on rails. The MR can be brought into the treatment room, the patient scanned, and then the MR is taken out of the treatment room and shielding doors are closed and the table turns around for patient treatment. Another example of a system that is currently commercially available is the ViewRay system. This is an MR-guided treatment unit. It employs a cobalt unit, although they've recently introduced a linear accelerator, and it uses a low field strength MR, only 0.3 Tesla, to help avoid some of the problems that you run into by merging a treatment unit with an MR, technologies that are not really compatible. At MD Anderson, we're working with Philips and Elekta on their solution, which is to combine a 7 MeV linear accelerator with a standard diagnostic quality 1.5 Tesla MRI by mounting the linear accelerator on a gantry around the magnet. And in these next few pictures, I'll show you the installation at our site. The gantry was brought in first, and we had to actually raise the floor so we could create a pit for the gantry to rotate in. Excuse me. Then the linear accelerator components were mounted on the gantry. The magnet was moved into the room and centered within the gantry. And then the RF cage was built around the entire system, and a treatment couch was attached. And finally, with the covers on, this is what the system looks like today. So all the patient sees is something that looks like an MRI. And here are images from this system. They are diagnostic quality because it is a diagnostic 1.5T magnet. Images from the MR Linac on the left and in the center, and from a diagnostic MRI on the right. Now, one of the things that I've mentioned before is that we can take rapid images and demonstrate motion. And in these pictures, we're showing a target volume, in this case in a healthy volunteer. They used the kidney to simulate a target volume, showing images taken in all 3 orthogonal planes, automatically identifying the kidney as it's moving and changing shape, and demonstrating those images 5 times a second. This opens up the opportunity for gating the radiation beam with the target or tracking the target as it's moving to keep the radiation beam on the target and away from normal structures. And to go further with MR in radiation therapy, we and others are exploring the use of MR-only simulation, treatment planning, and treatment delivery. And some folks in Sweden have developed the mechanism to create a synthetic CT image from MR images, which enables us to do heterogeneity corrections as part of our treatment planning process, so that it's not necessary to also have a CT scan. And as Dr. Gregoire alluded to, we don't need to generate extra revenue by doing unnecessary scans. In the US, they won't pay for it anyway. So if we can just do one set of scans and identify the target, but also plan the treatment, we're better off. So the workflow for MR-guided daily adaptive treatment might look like this, where on the left, the patient initially comes in and has either a CT or an MR simulation, and a reference treatment plan is generated. Then the patient, that takes place over a few days or a week. So when the patient next comes in for treatment, they're positioned on the table, and we would perform another 3D image acquisition with the MR component of the MR Linac. Then register those daily images with the reference images and edit the contours to account for changes in the shape and location of the target, and re-optimize the plan, create a new adapted treatment plan every day the patient comes in for treatment. Now, some QA will be performed electronically of that treatment plan, and while that's happening, we can perform additional imaging, possibly functional imaging, to look at the response of the tumor to previous treatment, or further investigate the control of the target. And then we begin treatment delivery. And during treatment delivery, we'll perform rapid imaging that I showed you in the previous slide to monitor motion, and delivery of the radiation will either be gated or tracked based on that motion. And then finally, the treatment will be completed. The manufacturer, Elekta, anticipates that this can all be done within about 45 minutes each day of treatment. with the benefits that every day the treatment is adapted so it can be improved each time and potentially optimized for treatment delivery, so that rather than using a single prescription every day, we might modify the prescription from one day to the next. Now, as with any new thing, there are questions about the biological effects of a device like this. So we've done some preclinical studies to demonstrate that there is no effect of irradiating cells in a magnetic field. And you might not be able to make out the graphs, but each of these graphs shows the cell survival of 4 different cell lines with and without the presence of a magnetic field, showing that the magnetic field had no influence on cell survival for the dose fractionation schemes that we used here. And we're going to follow this up with an animal study and irradiate mice with tumors with and without a magnetic field to, again, we hope, demonstrate that the presence of the magnetic field has no effect on tumor cure. Now, finally, in the last couple minutes, I'm just going to mention this other topic, emission-guided radiation therapy, or biology-guided radiation therapy. This is quite a new field, and it comes from the observation that, as Dr. Gregoire showed, PET imaging can demonstrate tumors in some situations, and in this lung cancer case, much more clearly than can conventional CT imaging. CT on the left, you cannot see that lung tumor, but on the right, it lights up and is very obvious. Well, a team in California have developed an emission-guided treatment machine, which contains a linear accelerator mounted on a circular gantry, the linear accelerator up at the top, and an imaging detector for the megavoltage beam behind it, and then mounted orthogonally to the, mounted orthogonally to the radiation beam are PET detectors, and you can see them here on each side of the patient. The whole assembly rotates, and as it rotates, the PET detectors detect the annihilation photons from the radionuclide in the patient. And when the gantry comes around to the point where the photons, annihilation photons, were detected, the accelerator delivers a burst of radiation to that point. And the process continues until the intended dose is delivered to the target. That's very new, and this company, Reflection Medical, is developing this device as we speak. So let me just summarize quickly the role of MRI. I'm going to jump back now to MRI. We've been using MR for diagnosis and staging for quite some time, but we're now on the verge of using MR only for simulation and treatment planning, and now for image guidance, as well as a daily adaptive treatment planning and daily assessment of tumor response, and then subsequent offline response assessment of the patient following the treatment. Pretty soon, I think, we'll be able to use MR for everything, certainly in a number of clinical sites where it is indicated. So I will wrap up there and thank my lab team and research colleagues at MD Anderson, and thank all of you for your attention.
Well, thank you, and I think we should break for our coffee, and if you have burning questions, we can talk at the coffee break.